In 1955, over 500,000 Americans lived in state psychiatric institutions. Today, fewer than 50,000 do. The deinstitutionalization movement promised community mental health centers as the replacement. The centers were underfunded, the severely mentally ill were often discharged without adequate support, and the largest psychiatric facility in the United States today is the Los Angeles County Jail. The gap between what mental health policy promises and what it delivers remains one of the most urgent public health problems in America. Deinstitutionalization was the dramatic reduction in psychiatric inpatient populations that occurred primarily between 1955 and 1994, driven by the introduction of antipsychotic medications, a growing civil liberties movement against involuntary commitment, and state budgetary pressures. The Community Mental Health Centers Act of 1963 promised to replace hospitals with local mental health centers, but the funding never materialized at the required scale. The result was a large population of people with severe mental illness discharged from hospitals without adequate community support, contributing to homelessness, incarceration, and inadequate care. Community mental health centers provide a range of services including outpatient individual and group psychotherapy, psychiatric medication management, crisis intervention, case management, rehabilitation and supported employment, and housing assistance. The community mental health model aims to provide accessible, local services that maintain people with mental illness in their communities rather than in institutions. Assertive community treatment teams provide intensive, mobile, wraparound services to individuals with severe mental illness in their homes and communities, one of the most evidence-based models for reducing hospitalization and homelessness. The treatment gap, the proportion of people with diagnosable mental health conditions who receive no treatment, is enormous in both developed and developing countries. In the United States, approximately 43% of adults with mental illness receive any treatment in a given year, leaving over half untreated. In low-income countries, treatment rates are frequently below 10% for the most severe conditions. The World Health Organization has identified the treatment gap as a global health crisis, particularly because effective treatments exist for most common mental disorders. Stigma, negative social attitudes toward people with mental illness, is the most frequently cited barrier to mental health treatment seeking. Public stigma involves negative stereotypes, prejudice, and discrimination by society toward people with mental illness. Self-stigma involves internalization of these attitudes by the person themselves, generating shame and a reluctance to identify as someone who needs mental health treatment. Stigma reduces help seeking, increases treatment dropout, and worsens outcomes. Contact-based anti-stigma programs, direct social contact between the general public and people with mental illness, show the strongest evidence for reducing public stigma. Beyond stigma, significant structural barriers prevent access to mental health care. Cost and lack of insurance coverage remain the most common barriers reported in surveys, with mental health parity laws, requiring equal coverage for mental and physical health, imperfectly enforced. Provider shortages are severe. More than half of U.S. counties have no practicing psychiatrist, and in many rural and underserved areas, the only available mental health provider is a primary care physician. Wait times for outpatient mental health care average 3 to 6 weeks in many communities. Telehealth has partially addressed geographic access barriers. Prevention in mental health is classified at 3 levels. Universal prevention targets entire populations regardless of risk, school-based social-emotional learning programs, public mental health literacy campaigns, and parenting programs for all new parents. Selective prevention targets groups at elevated risk, children of parents with depression, trauma-exposed populations, economically disadvantaged youth. Indicated prevention targets individuals who show early signs of disorder but do not yet meet diagnostic criteria. The strongest evidence for prevention effectiveness comes from early childhood interventions and from selective programs targeting high-risk populations. Mental health literacy, the knowledge and beliefs about mental disorders that aid recognition, management, and prevention, is a modifiable risk and protective factor for the treatment gap. People with better mental health literacy recognize symptoms of common disorders earlier, seek help sooner, know where to seek help, and are less likely to be held back by stigma. Population-level mental health literacy campaigns in Australia, Canada, and the UK have improved knowledge and reduced stigma at the population level. First aid-style mental health training, teaching laypeople to recognize and respond to mental health crises, has shown promise in systematic reviews. Crisis intervention addresses acute mental health emergencies, suicidal crises, psychotic breaks, and acute anxiety or mood episodes through time-limited, focused interventions designed to stabilize the person, ensure safety, and connect them to longer-term services. Crisis hotlines like the 988 Suicide and Crisis Lifeline provide immediate access. Mobile crisis teams, mental health professionals who respond to psychiatric emergencies in the community rather than sending police, are increasingly evidence-supported for reducing coercive interventions and improving subsequent treatment engagement. Peer support specialists, people with lived experience of mental illness, are an increasingly recognized component of crisis and community care. The gap between the mental health needs of the population and the mental health services actually received represents one of public health's most persistent failures and most significant opportunities. The treatments exist. The barriers are financial, structural, and social. Reducing the treatment gap requires addressing stigma, expanding access, training the workforce, and investing in prevention at a scale that has never yet been achieved.